This is Joe Rabban. I'm a professor of pathology at University of California, San Francisco. And I'm going to be presenting a session entitled Making Sense of Pathology Reports, Patient Empowerment Through a Pathologist's Point of View. These are my conflicts of interest. I will not be discussing any commercial products. I wanted to start out with first answering some practical questions that may not be intuitive to most patients. The first is, can a patient talk to a pathologist about their pathology report? And the answer is yes. Simply looking up the pathologist's name in the department records, you can arrange a time to speak to the pathologist, and we are usually more than happy to schedule a time to go over your report. Can a patient request a second opinion on their pathology specimen from another institution? The answer to this is also yes. If you have a procedure performed at one institution and you're going to another institution for a second opinion, you can also schedule for that second opinion to include a review of the pathology materials from the original institution. And your clinician can help you to arrange for that. A final question that I think is important for our patients to know is how long are pathology materials stored? And what I mean by pathology materials are the items that are listed here: the pathology report, the glass slides, the tissue blocks, any remaining specimen that is not entirely processed. There are federal guidelines that regulate this, and the path report and the glass slides are kept for a minimum of 10 years, and tissue blocks are kept for a minimum of 2 years. This becomes important as we think about tumor sequencing, because tissue blocks need to be available for that testing to be performed. This is the outline of what I'm going to discuss. 4 major topics. How do you as a patient benefit from reading your own pathology report? Number 2, what are the key pathologic variables that describe cancer in general? Number 3, where do you find those key variables in your individual pathology report? And then number 4 is a question that has emerged in recent years now that tumor sequencing has become more widely available. What exactly is tumor sequencing? So in terms of the benefits of reading your own pathology report or having assistants to go over the report, I think the 3 main considerations are to better understand the prognosis of the cancer, to better understand treatment options, and to better understand whether there is a possible hereditary basis for the cancer. In general, cancer care should be tailored to each individual patient. This is referred to as personalized care. And what this means is that the clinical team needs to have an understanding of a host of multiple details about the individual patient. One of those details being the details of the pathology of the cancer itself. And I think this is a good time to address some potential misconceptions about the term cancer. And I'm going to address this from the point of view of the pathologist. Cancer is a very general word. And when it comes to thinking about personalized care for an individual patient's management, we have to remember that cancer is not a single disease. It refers to a whole host of diseases that may have different characteristics. The term cancer is not a specific enough term to describe disease behavior. You need more information than just the word cancer to understand that. And the term cancer is not always correctly applied to describe disease. Finally, cancer is not always the term used for some tumors that actually have malignant behavior. And so it's important to be aware that the nomenclature that's used when we talk about cancer has many more nuances that need to be appreciated. And to give a practical analogy to this idea about the concept of terminology and meaning, I think it's helpful to think about the scenario of what does the term car mean to you? If you wanted to rent a car on a trip, I think if you typed in the word car in the reservation application, you would not be very happy if they just made a choice for you with any type of car that fulfilled the definition of car. obviously we have multiple scenarios for things that can be referred to as a CAR, and we all have our own preferences of distinguishing features when you think about renting a car, whether it's the number of passengers it can seat, whether it's off-road capable, et cetera. These are all very specific details that you would input when you want to make a rental of a car. You wouldn't just say, I want to rent a car. And the other issue is that you can rent other devices that are not called cars that could achieve the same goal of transportation. And so the point of saying this is that just as we would not consider the general term car to be specific enough to be useful in an individual situation, the same applies to the word cancer. And so the point is there are key pathologic features that distinguish cancer. These features are listed on the left-hand side, and I'm going to go through in more detail later in the talk to explain what each of these refer to. And the potential significance is listed on the right-hand side. So all of these variables can help to define the prognosis of the cancer. They can help to define the management decisions. They can sometimes help to predict response to therapy, and sometimes they can help to predict the risk of a hereditary syndrome. So the term cancer really is a general term that has embedded in it multiple different variables. So how do we understand the significance of all these pathologic variables that I have just shown on management decisions? There are multiple ways to answer this question, but I think probably one of the most useful ways is to think about the NCCN guidelines. NCCN refers to National Comprehensive Cancer Network. This is basically a one-stop resource for evidence-based cancer management algorithms. This is a not-for-profit consensus group supported by the US government. It's a multidisciplinary group made up of surgeons and radiation therapists, pathologists, geneticists, who are attempting to use the most currently available evidence in the literature and use the best evidence that is available to continually update these algorithms. And the goal is to improve benefits to patients by using the best available published evidence regarding cancer management. And so I'm going to give you an example here of the NCCN guidelines for endometrial cancer. And this is what it looks like. And this is just one example of the algorithms to demonstrate the point that tumor type in certain settings can drive management decisions. And so at these decision forks that are highlighted with the red arrows, you'll see that the pathologic type of tumor is one of the key drivers as to which pathway needs to be followed for management. This is another example showing how tumor grade and tumor stage are used to drive management. And you can see in the two columns for stage and grade that depending on what those variables are, the recommendations from the evidence may be different. So with that little intro to the benefits of reading your own pathology report, I now want to transition into talking in more detail about the key pathologic variables that describe cancer. So we'll start out with tumor type. So what is tumor type? Tumor type is a name given by pathologists based on the appearance under the microscope, and sometimes biomarkers are used to help define the name. And the three microscopic images that we see here are all different forms of uterine cancer that each have a distinct profile. So where do the names come from for the tumor type? They come from the classification system published by the World Health Organization. This is an international system that's designed and updated by pathologists using the best available published evidence. And this is updated every couple of years. What are the features that go into the tumor type? Well, as scientific advances have progressed, we now know that there are many more factors besides the appearance under the microscope that are important for integrating into the definition of the tumor type. And this includes things like epidemiology, clinical features, biomarkers, molecular alterations, hereditary risk factors, and response to targeted therapy. All of these variables are then synthesized into a classification system known as the WHO system. This is just an example of one of the classification schemes for uterine cancer. And what we see here are the lists of all the names of the tumor types, which are all unique from each other based on the parameters that I described. And this is an internationally accepted classification scheme, which has standardized criteria for definition. What about tumor grade? Tumor grade is a score that is given by pathologists based on the appearance under the microscope. The rules are different for each tumor type, but in general, the tumor grade is really a reflection of how close the tumor resembles normal tissue. And the relevance of this is mainly prognostic. And so in the two images shown in the bottom part of the slide, we have different appearances of endometrial cancer, one of which is called grade 1, because you can see these rounded structures that look much more like normal endometrial glands than the solid proliferation in grade 3. So the major point here being that there are different appearances that are used to assign different grades. Now, one of the complicating factors is that the terminology for grading is not standardized across all tumor types. And so it really depends on the tumor type as to what the terminology is going to be used. So for example, for endometrial cancer, we talk about grade 1, 2, or 3, but for ovarian serous carcinoma, we talk about high grade versus low grade. And so one grading system is not universally applicable to all tumors. You have to understand the exact tumor type. The next variable to discuss is tumor stage. So what is tumor stage? This is a code that is given by pathologists based largely on how far the tumor has spread beyond its starting point. Again, the rules are different for each tumor type. For certain tumors, the size is important, whereas for other tumors, it is not. What is the relevance of tumor staging? Again, it's prognostic. Where do the staging rules come from? Ideally, they come from long-term outcome studies of survival in which patients are grouped in cohorts together based on the characteristics of their tumor. And this is just an example showing the different survival rates for different stages of carcinoma. So for gynecologic cancers, there are two staging systems that exist, and they're essentially identical with a few rare exceptions. So FIGO is probably the most internationally accepted staging system. It stands for the International Federation of Gynecology and Obstetrics. And then the other system is called the AJCC stage. And the FIGO stage basically is a single stage, stage 1, 2, 3, 4, whereas the AJCC stage has three components to it. There is a T stage that refers to the tumor, an N stage that refers to the nodes, and an M stage that refers to whether or not there is metastatic disease. The stages are, or the two staging systems are relatively equivalent to each other. It's just the AJCC stage is a little bit more detailed. And so here's an example. These are the actual criteria for endometrial cancer staging, and you can see each tumor, node, and metastatic site has two columns, one for the AJCC stage and one for the FIGO. And let's say you had an example of an AJCC stage T1B and 2M1. You could look up on this conversion chart to see that this is the equivalent of FIGO stage 4B. And the value of tumor staging, besides being prognostic, is that anywhere in the world, these definitions mean the same thing to the oncologist in terms of predicting outcome of the patient. What about margins? Tumor margins can be important in certain tumors. This refers to whether the tumor has been completely removed at surgery. And it's really looking at whether there's any tumor at the edges of the specimen that has been removed. So in the example on the left, we see that the dark tumor mass is not at the bottom edge of the specimen, whereas in the right-hand figure, you can see that the tumor mass has been cut through by the surgeon, and that would be considered a positive margin. What about biomarkers? So biomarkers are special tests that are performed by the pathologist on the tumor, and this may include things called immunohistochemical stains, molecular diagnostic tests, or next-generation sequencing. The reason for ordering biomarkers is variable. Not all tumors require biomarkers, but they may be helpful in certain settings to determine the tumor type, to help screen for hereditary syndrome, and to help identify drug targets for therapy. Finally, hereditary risk. This is the last category of data that shows up on a cancer report. So there are some hereditary syndromes that have pathologic clues that should trigger referral to genetic counseling for formal risk assessment. And these are defined again by the NCCN as well as the American College of OB/GYN and the Society for Gynecologic Oncology. The two major gynecologic tumor syndromes are ovarian cancer and endometrial cancer. For ovarian cancer, the syndrome is hereditary breast and ovarian cancer syndrome, and the clues in the pathology are the tumor type of high-grade serous carcinoma. For endometrial cancer, the major syndrome is Lynch syndrome, and the pathology clues are mismatch repair stain defects. There are also a growing number of less common GYN tumors that are associated with syndromes that also may have pathologic clues. And some of these are listed in this table here. The main point that I'm trying to make is that when you read the pathology report, depending on the tumor type, there might be a mention of this, and the pathologist may advise referral to genetic counseling, and this is the reason why. So we've covered all the key variables of a cancer report. The next question from the patient perspective is, where do you find those variables in your pathology report? It's not a straightforward answer. And so what I'd like to do is walk you through the different sections of a pathology report. So the clinical history section, this is where the information provided by the surgeon to the pathologist at the time of submitting the specimen is entered. The gross description section is a narrative description of all of the specimens that the surgeon submitted. And it's a description based on simple visual examination, including measurements of the different organs or tumors, and a description of how the tumor was sampled for microscopic examination. One thing that you may note in the pathology report is a discussion of specimen parts. What this refers to is that if there are more than one specimen that is removed by the surgeon, they may submit them in different plastic containers, which we refer to as parts. And the significance of this for the pathology report is that each individual part will receive a separate gross description as well as a separate final diagnosis. And so in this example, where there are 5 containers submitted, you can see that there are different organs that have been placed into the different containers. And the surgeon may have a very specific reason for separating them out into these different containers. For example, with the lymph nodes, if they want to know whether it was the right side or the left side that contains metastatic disease, the only practical way of doing this is to separate the specimens at the time that they are delivered to the pathologist. So this is a good time to basically give an overview of the journey of the specimen from the operating room to the final pathology report. So if we start in the upper left-hand corner, this is a uterus. This is a hysterectomy specimen. We then open the uterus, that's the middle image, and then the upper right image, we serially slice it so that we can examine all aspects. And then we take sections of the relevant parts of the tumor. We place them in these green plastic cassettes. They're about the size of a quarter. And then those tissue sections can eventually be processed and mounted onto glass slides, which are then reviewed under the microscope by the pathologist, who then eventually creates the pathology report. Going into a little bit more detail about the tissue processing, we place the tissue in these plastic cassettes that have a lid that locks on. You can see that there are perforations or holes in this cassette, and that is to allow chemical fluids to flow in and out in this machine called a processor, which basically dehydrates the tissue and prepares it for our staining protocol. Once that chemical processing is finished, the tissue is then embedded in wax or paraffin to create these blocks. And the tissue blocks are then cut very thinly, and the sections are mounted on glass slides. And this is an example showing how the tissue blocks are mounted in a device called a microtome that has a very sharp blade, which then is able to cut very thin sections that are mounted on a glass slide. And many things can be then done on that glass slide. We can do routine staining, we can do immunostaining, we can do molecular tests like FISH. So there are many options that are available once these slides are created. And again, this is all described in the gross description component of the pathology report. Probably what most patients are interested in is the final diagnosis. And this is basically the diagnosis for each of the specimens that is submitted. There's another very important component of a cancer pathology report called the diagnostic comment. And the two things that are included in the diagnostic comment are something called the tumor synoptic, which I will explain, and then any discussion by the pathologist of difficult issues with the case. So if the case has some challenging features that require extra work in order to verify the tumor type, there may be a narrative description of the process that the pathologist used in order to resolve that question. And that would be found in the diagnostic comment. Finally, there is a section called an addendum. This is not present on every case, but if you see it, it is a way to basically tack on additional information that was performed at a later date, such as biomarker information. So I referred to the term tumor synoptic. What is this? This is actually a very important part of the PATH report for cancer. It's a template of standardized variables that must be reported for a cancer in the United States. Each organ and each major tumor type has its own unique template. And these are based off of evidence-based criteria for data that will be helpful for not only prognosis, but also for helping the oncologist determine the right management after surgery. Where do these tumor synoptics come from? They are developed by the College of American Pathologists. They're updated pretty frequently based on new evidence that gets published, and they're freely available for public access at the website that I've listed here. This is an example of what a tumor synoptic would look like for endometrial cancer. These are all the variables that will show up in the report. And the main point that I'm trying to make is that these variables are going to show up in any cancer report in the United States, no matter what institution you go to. It's a standardized process. Okay, so we talked about key variables that define cancer in terms of prognosis, response to therapy, hereditary risk factors. Where do you find those variables in the pathology report? Well, typically the tumor type and grade are going to show up in the final diagnosis. The tumor stage, margins, and biomarkers typically show up in the synoptic comment, in the diagnostic comment of the report. And then occasionally biomarkers can show up in the addendum component of the report. So these are the key areas that you want to look at. This is an example of an endometrial cancer report. And we can see here the final pathologic diagnosis. There are 4 parts, A, B, C, and D. And in the red arrows, I've highlighted the tumor type, the tumor grade, where they show up in these reports. This is an example of that tumor synoptic for that case, and we see all the standardized variables. And you can see where the red arrows are, again, the tumor type, the tumor grade, the margin status, and both the AJCC and the FIGO tumor stage. In this particular case, there's an addendum comment, and this is where the discussion of hereditary risk factor screening is reported, along with the results of the special tests that were used in this case to screen for, in this case, what we call Lynch syndrome in endometrial cancer. Okay, so that was a summary of the different variables in the path report and where to find them. The final issue that I'd like to address is the concept of tumor sequencing, as this has become more widely available in recent years. As a patient, you may have read about this. What exactly is tumor sequencing? It refers to any of a number of molecular tests to look for genomic alterations in the tumor. And so this is different from doing a genetic germline test, where you're looking at a blood sample for alterations that are present in all of the cells of the body. Tumor sequencing generally refers to looking for alterations that are in the tumor itself. So examples of alterations include gene mutations, gene deletions, gene rearrangements, or gene amplification. There are many others, but I've just listed a few. Why would you want to know this information? Well, the potential value of finding alterations in the tumor is to help clarify or confirm tumor diagnosis, to help predict prognosis, to help predict response to a very specific form of chemotherapy, or to predict risk of an inherited tumor syndrome. So the indications for performing tumor sequencing really depend on the specific tumor. Is this necessary in all cases of cancer? No. But it's beyond the scope of my presentation here to indicate exactly which types this is indicated in. And as I mentioned, the limitation of tumor sequencing is that this is not a genetic germline test. This is a test to look at what is going on in the tumor. Now, there is a way to obtain germline analysis if a sample of normal tissue is also sequenced at the same time that the tumor is sequenced. And that is something that is offered in certain situations. But in general, the main takeaway point is tumor sequencing is really looking at what we call somatic alterations in the tumor itself. So how does this get done? Well, depending on the tumor and the particular medical center, either the surgeon or the pathologist will order the test. Insurance coverage varies by insurance and by tumor type. The testing is performed on a tissue block of the tumor from surgery, and that's why I wanted to go over the process of how these tumor blocks are created, just to give you context of where this test is being performed. So tumor sequencing, as I mentioned, has now become more widely available. There are a number of commercial laboratories that offer this. And so you may hear your clinician say that they would like to have the tissue block sent out for testing. And what that means is sending one of these tissue blocks out to one of these commercial labs for the testing. There are some pathology practices, mainly in academic settings, in which the tumor sequencing is offered in that pathology department. The results are reported and interpreted by physicians. These are usually pathologists who are certified for molecular diagnostic test reporting. So before I conclude, I just want to come back to the original practical questions that I raised. Can a patient talk to a pathologist about their report? Absolutely. Can a patient request a second opinion on their pathology specimen? Absolutely. It's just a matter of picking up the phone and arranging for this. And then again, just be cognizant of the amount of time that records are stored, so that you're not surprised if a pathology department says that they no longer have access to that material. So with that, I will conclude, and I hope that this has been a practical introduction to taking a look at your own pathology report. And if there are any questions, my email is available online, and I would be happy to engage in any further discussions. Thank you very much.